Welcome back to The Explainer, everyone. I am absolutely thrilled to jump into this with you today. We are going to completely decode the complex CPT rules surrounding non-face-to-face evaluation and management services. Look, healthcare has rapidly evolved way beyond the traditional exam room, and our coding has to reflect that reality. But as we all know, with new codes come new rules. So let's get right into it.
I want you to really think about your practice for a second. When it comes to remote services, we are dealing with a massive double-edged sword. On one side, you've got providers doing incredible, time-consuming consultative work behind the scenes and never billing for it, literally leaving legitimate revenue on the table because they're undercoding. On the flip side, you have practices that are actively billing these codes but completely ignoring the incredibly strict timeline guardrails. And you know what that does? It invites a massive, crushing audit. Today, we're going to fix both of those problems.
Here is our game plan for today. We'll start by demystifying non-face-to-face services, then dive into peer-to-peer interprofessional consults, followed by patient e-visits and digital E/M. After that, we'll cover the crucial consent and anti-overlap rules, and finally, wrap up with how to avoid those top audit red flags.
All right, Section 1, Demystifying Non-Face-to-Face Services.
So looking at the official AMA guidelines, you'll immediately notice a very deliberate separation of services. To prevent total administrative chaos, CPT guidelines require us to bucket these codes into two very distinct communication paths. One path is strictly provider-to-provider, which are your interprofessional consults. The other path is patient-to-provider, which are your online digital E/M services, also known as e-visits. Mixing these two up? Yep, that's pretty much a one-way ticket to a denied claim. Keeping these buckets mentally separate is exactly how we ensure accurate reporting.
Moving right along to Section 2, Peer-to-Peer Interprofessional Consults.
So what exactly is an interprofessional consultation? Basically, it's a non-face-to-face assessment and management service. Picture a treating physician or a qualified healthcare professional who's stuck on a tough case or maybe just needs some quick guidance and requests an expert opinion or treatment advice from a specialist consultant. The absolute key here is the clinical scope. This interaction happens via telephone, the internet, or an electronic health record system, and the patient is not in the room. It is strictly a peer-to-peer interaction.
Now, if you are the consultant doing the heavy lifting, how do you choose the right code? Well, it all boils down to one crucial distinction. Did you actually speak to the requesting physician? If you, as the specialist, spend 5 or more minutes reviewing the medical record and only send a written report back with zero verbal discussion, you're going to use CPT code 99451. But if you provide a verbal opinion over the phone and send a written report, then you shift over to the 99446 through 99449 series.
If you fall into that second category, where both a verbal discussion and a written report actually happened, time becomes the name of the game. Let's break down these specific tiers. For 5 to 10 minutes of consultative discussion and review, it's 99446. For 11 to 20 minutes, report 99447. For 21 to 30 minutes, you're at 99448, and if you spend 31 minutes or more, you max out at 99449. Just remember, the majority of this time absolutely must be devoted to the medical consultative verbal or internet discussion. If you're mostly just quietly reviewing data, you cannot report these codes.
But wait, what about the doc who actually asked for the help? They put in work too, right? Exactly. And that brings us to CPT 99452. This code is specifically for the requesting or treating physician. If they spend 16 to 30 minutes in a single day preparing the referral, pulling all the records, or communicating with the consultant, they get to report this code. However, there is a very strict limit. You can only report this once per 14-day period.
Let's pivot to Section 3, Patient e-visits and digital E/M. I honestly love this part because it's just so relevant to how medicine operates today. But listen, the rules for online digital EMM, which are codes 99421 through 99423, are incredibly specific. First off, they are strictly for established patients. You cannot do an e-visit with a brand new patient. No exceptions. Second, the contact must be patient-initiated. The patient has to be the one reaching out through a secure online portal, EHR messaging, or an encrypted email with a clinical inquiry. You can't just proactively email a patient and then drop a bill for it.
Here's where it gets kind of fascinating. Unlike those single-day consult codes we were just talking about, digital EMM codes run on a cumulative clock over a 7-day period.
This includes all the time the physician spends reviewing that initial inquiry, digging through records, developing a management plan, ordering tests, and sending messages back to the patient. You tally all of that up over 7 days. If it totals 5 to 10 minutes, you bill $99421. For 11 to 20 minutes, it's $99422. And for 21 minutes or more, it's $99423. And remember, you only bill this once per 7-day stretch.
All right, Section 4. Consent and anti-overlap rules.
Okay, before you even think about billing any of the codes we've discussed today, you absolutely need this: patient consent. Both interprofessional consults and digital EM visits require advance verbal or digital consent, and it literally must be documented in the medical record. Why? Because the patient might not physically be sitting in your waiting room, but their insurance is still getting billed. That means they could very well be on the hook for cost sharing or a deductible. They have every right to know upfront that this digital convenience comes with a standard medical charge.
Now, let's map out what I call the 14-day look-back and look-ahead rule for interprofessional consults. It's a massive trap that so many practices fall into. Here's the deal. The consultant cannot bill for the peer-to-peer consult if they saw that patient face-to-face within the previous 14 days. That's the look-back. Looking ahead, if that telephone consult leads to a transfer of care or an in-person visit with that same consultant within the next 14 days, or even the next available appointment, you don't report the consult code. That work simply gets bundled into the upcoming face-to-face visit.
Patient e-visits have their own tricky timeline exclusions too. If a patient fires off a portal message, you have to look back. Did this inquiry originate from a related E/M visit that happened in the previous 7 days? If it did, nope, you cannot bill the digital code. Similarly, you have to look ahead. Let's say you spend time on the digital EM, but ultimately realize, hey, this patient really needs to come in, and they are seen for an in-person visit within 24 hours or the soonest available appointment. In that case, all that digital time is just bundled right into the in-person visit.
Finally, Section 5. Avoiding top audit red flags. If you really want to build an absolute compliance shield around your practice, you need to memorize these top audit triggers. First, like we stressed earlier, absolutely never bill 99446 through 99449 if you do not have a clearly documented verbal discussion between the providers. Second, do not report digital EM for a routine prescription refill or just simple administrative scheduling. Those do not meet the criteria for medical decision-making at all. Third, missing that advanced patient consent will fail an audit instantly. And lastly, double counting time is a huge, massive compliance risk. You cannot count the same minutes you spent reviewing data for an e-visit toward chronic care management or remote patient monitoring. You never, ever count the same time twice.
So, I want to leave you with a question to chew on. Look at your own charts tomorrow. Is your documentation actually creating a compliance shield, cleanly separating those provider consults from patient e-visits with pristine time logs? Or is it an audit trap, missing consent and dangerously overlapping with in-person visits? Master these rules, and you master your practice's health. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.